is Tamaris Fierro, and I'm going to talk about renal cell carcinoma. Definition: renal carcinoma is the most common cancer of the kidney and begins when cells in the kidney grow out of control and outnumber normal cells. It often begins as a tumor in one kidney that may spread or has spread to the other kidney or to other parts of the body, such as the lungs or lymph nodes.
Renal cell carcinoma is the most common type of kidney cancer in adults. It accounts for approximately 3% of adult cancers, and the incidence has risen steadily by about 2 to 4% each year in the past few decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones. While the exact cause of renal cell carcinoma is unknown, there are risk factors that increase the chance of developing it, such as smoking, high blood pressure, family history of kidney cancer, and obesity. The chance of developing renal cell carcinoma increases with the age, and males have double the chance of having it compared to females. In a lot of patients, this cancer may not produce any symptoms for most of its course. Only about 10% of patients present with the classic triad of flank pain, blood in the urine, and lump in the abdomen. Other signs and symptoms may include unexplained weight loss, fever, night sweats, weakness, fatigue, nausea, and high blood pressure. Renal cell carcinoma is associated with a number of paraneoplastic syndromes, which are conditions caused by either the tumor hormones produced by the tumor or by the body's attack on the tumor. In about 20% of these patients, paraneoplastic syndromes are present, such as high blood calcium levels, high red blood cell count, high platelet count, and deposition of amyloid protein in one or more organ systems. To diagnose renal cell carcinoma, signs and symptoms and past medical history play significant roles. Based on the symptoms and signs, a range of biochemical tests are considered to provide sufficient diagnostic clues. Kidney imaging is vital, mainly consisting of ultrasound, CT scanning, and MRI scanning of the kidneys. Biopsy of the suspected kidney mass helps confirmation of the diagnosis. To evaluate the extent of cancer spread, PET scanning is the standard imaging modality. The therapeutic approach to renal cell carcinoma is guided by the stage or degree of tumor spread, pre-existing medical conditions, and overall health and age of the person. The principal treatment options for renal cell carcinoma consist of surgery, immunotherapy, and targeted therapy. Partial or complete removal of the affected kidney is the standard treatment for localized renal cell carcinoma. Immunotherapy, or biologic therapy, works by boosting the body's immune system to help destroy cancer cells. Cytokines are the artificially engineered versions of natural proteins that activate the immune system, and the ones most often to treat kidney cancer are interleukin-2 and interferon alpha. The targeted therapy works by blocking growth of the new blood vessels that nourish cancer cells or downplaying important proteins in cancer cells that help them grow, or both. Clinical response rates with chemotherapy, either monoagent or combination, are usually less than 15%. Renal cell carcinoma is not very sensitive to radiation, and radiation therapy is more often used to palliate or ease cancer symptoms in case of cancer spread. For more information about list of expert doctors, hospitals, and ongoing clinical trials, please visit www.expertdocs.com.
Applications in medicine. 75% of clear cells renal carcinomas have mutations or epigenetic silencing of the VHL gene. The VHL gene encodes a protein, PVHL, with two isoforms, both with tumor suppressor activity. Its loss of function conditions the activation of hypoxia pathways.
Renal cell carcinomas, or RCCs, are the most common type of malignant kidney cancer in adults, generally affecting older men. Unfortunately, RCC is often considered a silent cancer because symptoms don't typically get noticed until the tumor has grown pretty large. Renal cell carcinomas form from epithelial cells in the proximal convoluted tubule of the kidney. And this is the section of the nephron that's usually located in the renal cortex, the outer rim of the kidney. The most common type of renal cell carcinoma is composed of polygonal epithelial cells, which have funny angular shapes with at least 4 sides, and are filled with clear cytoplasm full of carbohydrates and lipids. And it's those lipids that give the tumors their yellow color.
Sign up for a free trial today and watch the full video on osmosis.org.
Pros and cons. Pros. Cabozantinib versus Everolimus is used for patients with metastatic renal cell carcinoma whose tumors did not respond to the first treatment, or for those who relapse after treatment. Cons. The most common serious side effects experienced by cabozantinib treats patients include diarrhea, hypertension, and palmoplantar. Other side effects include fatigue, nausea, decreased appetite, and painful mouth sores.
Small renal masses are among the most common kidney tumors urologists see in clinic. Small refers to solid tumors 4 centimeters or less, and 4 centimeters is about the size of a golf ball. If we removed all of the 4 centimeter tumors, we know that 20 to 30% are benign tumors, and of the cancers, the vast majority are low-grade indolent tumors, meaning a benign behaving cancer. Certain characteristics can change those numbers. Women are more likely to harbor benign tumors, and the smaller a mass, the less likely it is a dangerous tumor. For masses smaller than 2 centimeters, the risk of that being a kidney cancer that would spread from the kidney is less than 1%. For a 3 centimeter mass, it is about 1 to 2%, and for masses greater than 4 centimeters, it can be 5 to 10%. Given the understanding that most small renal masses are not dangerous, there are a few options for management of these tumors. Many patients choose surgery, and this can include surgical removal, freezing or burning of the small renal mass, and preservation of the kidney, and in some cases, removal of the entire kidney. An alternative to surgical options is active surveillance. Active surveillance refers to careful monitoring of both a patient and their small renal mass to make sure that it is not growing or changing in a dangerous way. Urologists at Johns Hopkins are among the leaders in active surveillance for small renal masses, and the DISSRM registry, Delayed Intervention and Surveillance for Small Renal Masses, or DISARM, has been open since 2009, cataloging the outcomes of hundreds of patients who chose to follow their small renal mass rather than undergo surgery. Since 2009, we have learned that most small renal masses, about 80%, grow very slowly or not at all. Some small renal masses will grow at a suspicious rate for aggressive cancer, and we do recommend surgery in about 15% of our patients. Importantly, no patients have had kidney cancer spread from their kidney, and no patient has died of kidney cancer in our program. Active surveillance involves periodic imaging with either CT scans, MRI, or ultrasound, and annual laboratory testing to ensure general well-being and kidney health. Imaging is typically recommended every 6 months for 2 years to establish a baseline growth rate, and then annually thereafter if a small renal mass remains stable in size. Renal mass biopsy, urine tests, and molecular imaging can be used to guide management in some patients. At Johns Hopkins, we recognize that not all small renal masses require immediate surgery, and we work with our patients to develop an individualized plan for active surveillance to keep a close eye on their small renal mass and ensure their overall good health.
Worldwide, renal cell cancer has an incidence of 2.4% in both sexes, a mortality rate of 1.7%, and a 5-year prevalence of 2.8%. In Ecuador, according to data from the National Institute of Statistics and Census, renal cancer is more frequent in men with 2.5% and women with 0.9%. Estimate age, standardized incidence and mortality rates, both sexes worldwide. Mortality due to cancer in the male population in Ecuador. Mortality due to renal cancer corresponds to 1.7%. Conclusion: the incidence of renal cancer has increased at a rate of 2% per year over the past 65 years, as has the mortality caused by it over the past 2 decades. Surgical resection remains the treatment of choice for localized tumors. As for the controllable risk factors, it is necessary to have an adequate lifestyle in order to reduce the risk of cancer, such as obesity, excessive consumption of cigarettes, and the use of tobacco, among others. Thank you.